Welcome back to Jeff Koinange Live here at Citizen Television. We're going to go straight to the screen here. You're looking at live pictures. Washington, D.C. That's right, the U.S. Capitol. There were protesters out there in the streets of Washington waiting for Congress to make an announcement. Basically, that Vice President-elect Joe Biden was going to be the next president. President Trump didn't want that to happen, and he had asked his VP, Mike Pence, to say to that effect. He did not. These people here just stormed the equivalent of our parliament here in Nairobi. They just stormed it, the U.S. Capitol building. Look at that, live pictures. They are inside that building. Dr. G, Dr. Lois, in America, this is happening right now in America.
Democracy on trial. It's democracy on trial, really. And I think it is, I was just having a chat with Dr. Lois, and you say, why would, the U.S., as our beacon of democracy, allow this kind of thing to happen?
Allow this to
happen.
How?
That's what we're asking.
That doesn't make sense.
I mean, okay.
And it starts as a joke, but it can quickly spiral out of control.
Correct. Starts as a joke, and this is what it ends up as.
Exactly.
And President Trump has done nothing to calm these people down, by the way. If anything, he's been encouraging them. Still thinks he'll be in office in...
on 20th.
On the 20th, yeah, 21st, correct.
After midday of 20th.
Correct.
Yes.
Can you imagine that?
Yeah. This tells you how toxic politics is. And
exactly 2 weeks from today, he's out.
Yes. Politics can be very toxic.
Wow, and their cases are climbing higher by the day, by the way.
It's a lesson for us that we must keep our politics on the straight and narrow and moderate.
By the way, we'll keep you updated on what's happening in the U.S. Capitol throughout this JKL, but unbelievable scenes there, unbelievable. And speaking of U.S., Dr. Lois, 350,000 plus dead. Dead.
So, I mean, one, we have to admit that they have a very large population, 350 million or thereabout. But having said that, that is still an astronomical death toll. And a lot of it has really been driven around this period, the campaign to election period, by a lot of public gatherings. There's a season when they had a lot of the Black Lives Matter protests, and after that we saw a surge. Shortly after that, the campaign season heated up, and there were a lot of gatherings, and the election period came up. So with all these gatherings, they've had a lot of cases. What's unfortunate is that a lot of hospitals are actually getting overwhelmed, and we've seen in the news very sad news about, ambulance services being told, if someone can't be resuscitated, don't bother putting them in an ambulance, because why waste the resource? There are other people who need it. Just leave them there, So that's really sad. If you think of a country like America, where we thought healthcare is available to everyone, is getting overwhelmed. It's very, very sad.
It is.
And as a hospitals, this is one thing we've always said in the past, even to us, don't allow hospitals to get overwhelmed, because the minute hospitals get overwhelmed, the death toll climbs
And that's
up.
your biggest fear, right?
Yes.
So you're saying
we never want hospitals to be overwhelmed. Do whatever it takes to allow us to be able to take care of those who are sick, because the minute it's overwhelmed, more people die because we are not able to give them the care that they need. Healthcare workers get infected because they're overwhelmed and tired and unable to protect themselves. So we always have to be careful not to overwhelm our system.
Does it shock you when you see some of those pictures on CNN, on BBC, those hospitals completely overwhelmed, and the staff members?
And people abandoned outside. It's very, very bad. And staff members crying out because they need a mask, for example. They're using cloth masks within the hospitals. It's a very sad picture. And I think now that we know that, we have the benefit of having seen other people get there early. Let's learn lessons from there to ensure that we never allow ourselves to get overwhelmed.
Yeah. Dr. G, we were talking before the break about a vaccine, and there's a whole process. And we are going to get ours. We are on the list. How does it work?
So the vaccine process, of course, there has been a call to ensure that vaccine access is equitable, meaning it gets to everyone, irrespective of whether you can afford it or not. And because of that call, WHO and the Global Vaccine Alliance and other people, CEPI and others, got together and created what's called the COVAX facility. The COVID vaccine facility says we are going to allow the rich countries to buy, because they have the money. Let's face it, they have the money. Our per capita GDP is low, they have high GDP, they can afford. The arrangement is that as you purchase from a rich country, part of that money is allocated to some vaccines that are going to be available to poor countries. So it's kind of a process called advanced market commitment. So when they commit to 1 million doses, some of that is allocated to this other channel, which is going to go to low-income countries. So that has raised quite a few doses. I think by the time I was checking, maybe about 2 billion doses already raised through that facility. Now, what Gavi then does and WHO, there are countries which are eligible for that facility. Those countries are the countries that are already receiving vaccines from Gavi. Kenya is one of them. Kenya, most of our vaccines, and Dr. Lois will know, polio, TB, all of them are actually supplied through Gavi. But Kenya, because of its development, is contributing about 20% of the money for that. So this COVID vaccine is going to come through exactly the same mechanism. Gavi will deliver it just the way they deliver other vaccines. Kenya will contribute 20%, just like it contributes for the vaccines, and then the vaccine will come here. So the challenge now is that because Kenya has no control, it can't go to the market and say, we want our 24 million doses, bring them here. So the process is Kenya had to apply by 7th, like all the other countries that are eligible, and there are many, and those countries, there are almost 100 countries, I think maybe 92, would then be allocated first come, first served, based on the available doses, okay? And then those doses will be delivered by Gavi. So it's not like Kenya is saying, you know, we have refused to order, we are going to order, and then this day, even deciding when the vaccines come here and how, and even which ones we receive. Because imagine that if this facility goes and wants 2 billion doses to be distributed to these eligible countries, but one vaccine manufacturer can only afford to give 500,000 doses, right, or 500 million doses. They have to go to the other, and then the other, and the other. So even in terms of the question around, which one is Kenya going to take? Is it AstraZeneca? Is it Moderna? Is it Pfizer? Kenya has no control over that. It's going to be actually this facility. But eventually, as the markets open up, there'll be more vaccines available from China, the India serum. The India is manufacturing on behalf of all these others and bringing on. Remember, by the way, Jeff, and I need to say this, vaccine capacity has never, ever been adequate for what is required now. Right now, you're talking about a population of 7 billion people. Even if you wanted to vaccinate only 5 billion of them, so that you at least reach the threshold of 60-something%, that is 10 billion doses. The biggest vaccine manufacturer in the world, the Serum Institute of India, which is what manufactures most of the vaccines that come to Asia and Africa, has only a capacity of 1.5 billion doses a year. Okay, so when you're talking about delivering 10 billion doses, it is not a 1-year activity, it's not a 2-year activity, it's not a 3-year activity. So the vaccine satisfaction is going to take maybe even 4 to 5 years. But the focus now is on the 20% of people, as Dr. Lois was saying, who are at the front line, health workers, those people who are highly at risk, because again, vaccines are a decision. If you're very low risk, if your risk is 0.2%, and my risk is 16%, then I get the vaccine before you. It's also a risk and benefit analysis.
Sure.
So we'll get first the 20%, which is about maybe 24 million doses. That's about 11 million people. And in that cluster is health workers, police, teachers, people who are elderly, people who have hypertension and diabetes. Then the rest of the population will get it in the next phase. When is that next phase? We don't know.
Wow,
and
okay.
maybe just to add to that,
Yes.
remember, it's not just about getting the vaccine. There has to be a lot of capacity development.
Exactly.
Our systems have been made for vaccinating newborn babies and children under 5. Now we are expanding this beyond what we have vaccinated before, which means you have to think about the other resources, the human resource, the gloves and, everything else that we may not think about now. If you think about some of these vaccines, we've heard about the issues of storage. So if a vaccine requires a certain temperature, do we have any of those freezers in country? How do we get them? And how do we maintain them in Turkana, for example, in a hot, hard to reach place for it? So there are other things that have to be put in place to ensure that it is available widely. It's not concentrated in Nairobi. It's actually available throughout the country as well.
Very valid points there. And, it comes back to something you had said earlier on, Dr. Lois. You said, is the world is, let's face it, the world is surprised that we're not dying like flies. Let's face it. I'm not being unfair or unkind here. The world is shocked that we're not dying like flies. And you said it could be what? It could be anything. We don't know. Could be our melanin levels, could be our,
It could be our previous exposure. It could be our generally younger population, lower prevalence of some of these comorbid conditions than you'd see in the West, for example. It could be a combination of things. But having said that, one death is still one death too many.
Dr. G, what do you think? I agree with Dr. Lewis. There
are many factors. There are many factors. The first one I would like to disabuse is this issue about melanin, in my view. Because if you look at the deaths in America, they're largely blacks and Hispanics.
Yeah.
They have the same melanin levels. So I would say there are other factors. And I would say that the factors have to do with the age, for example. We've seen the risk factors. As I said, only 9% of our positive cases are people below 19 years. And they are in the community, Even when you come to the mortality, only 2% of all total deaths are actually people under 19. And majority of them are children under 1 year. They're actually infants. So when you look at the age between 10 and 19, very few people have had actually, have been, and as we say, we must always remind people that every life matters. So when you talk about numbers, we're not saying that life doesn't matter. We only talk about numbers to explain the bigger picture. Right. So that's important to know. But when we talk about youth, number one, secondly, obesity. That is something that we haven't factored in a lot. That actually when you talk about risk, obesity and the risk for diabetes and hypertension is a big risk for severe disease. And this is why we are seeing a lot of severe disease in South Africa. Because South Africa has one of the highest obesity prevalences in Africa. Actually in the world.
Is that right?
Exactly. Like women, more than 40% of women are classified obese, a big percentage of men, and that is contributing to the severity of the disease in South Africa. Okay, so again, obesity, if you look at the obesity percentage in Kenya, it's much, much lower. The US obesity is more than 30%, in Europe is more than 30%. In most African countries, it is much, much lower. So that could be the next factor. The other factor is about movement and the force of transmission. If you have 1 million people in one space, it is likely that the virus will pass very quickly between them. But if you have 1 million people within 100,000 square kilometers, I mean, at what point does the virus move from one person to the other? So in between there is the index of mobility. And when you look at Africa, mobility is very low. I mean, how many countries in Africa have rail systems?
Airports.
Airports. Mass transit systems. Right. Look, we're doing our first we're still thinking about mass transit buses.
Correct.
So those factors have to, have come into play in terms of the rate of infection and also the rate of severe disease and mortality.
Wow. You know what? I could ask you questions all evening, but that'll be so unfair. So let's go to the magic wall. Let's get questions from the folks. I know they're asking all kinds of questions. So here we go. Bore Collins, some are comments, some are questions, okay? As a teacher, I've had to adjust to the new normal. Guiding students on the protocols by Ministry of Health is the first thing before teaching. Like a section of Kenyans who wear masks to escape arrests. Some students wear masks only when they see a teacher.
And that's true. They've learned from us.
They've learned bad habits from us.
Exactly.
Good Lord. Kian, the love doctor. Oh, really? The love doctor? Are you kidding me?
So now we have 3 doctors in the
room. I saw a kid taking a razor and cutting a straight line across the mask so that he speaks properly like a puppet. I had to buy another mask for him. Children have no idea what we're dealing with. Just having fun in masks like superhero movies.
And this is where we said protection starts at home.
Exactly.
It's a role of the parents, the guardians, the caregivers to talk to the children before they get to school. It's not for the teachers to teach the children once they're in school.
Right.
The teachers will be overwhelmed. It has to start at home.
Doctor, do you agree?
I agree entirely. And as we said, remember, the Swiss cheese strategy.
I love it.
That the fact that if the school is attempting social distancing, the community is doing what they need to do, the child is wearing the mask maybe 1 hour instead of 6, the child is washing their hands, all these things work together.
And you know, there's something the CS education, Professor Mago has said, that people should learn under the trees. And of course, there's backlash. Why aren't you building classrooms?
Correct.
But it's actually pretty safe to learn under the trees.
Yes.
You know, the risk of transmission under that tree is minimal. So if it is possible, it sounds wrong, but it actually will reduce transmission.
He got a lot of flack for that, huh?
Exactly.
My God, the backlash. Victor Peters, he says, social distance and other protocols are observed when ministry officials visit a school. Today, my kid at Olympic Primary said there were 4 kids at a desk. Oof. Dr. G.
No, you know, when I was in primary school, there used to be a person, I don't remember the name, but by definition, their role was called Education Officer, EO. And whenever we were told by the headmaster that the EO is visiting, we spent 2 days cleaning the school, cleaning the toilets, and when he came, we got the marks. Then as soon as they went, the toilets were smellier than they were before. You know, so this is not like new behavior. And it's also about, as we talked about earlier, it's about our own community behavior. Are these things entrenched in us as habits, or have we also shown our children, even at home, that we only obey the lights when there is a policeman and you're carrying them in the back? Why wouldn't they also obey the mask only when there is a teacher? So it's a whole societal issue.
Yeah.
And again, Swiss cheese, right? I mean, even 4 kids per desk, Dr. Lois,
so
as long as you're
I mean, we have to say 4 kids per desk is not ideal.
Right.
We would hope that there is more, but we also have to live with what we have. You're not going to send some children to school or back home. So this is the situation where wearing that mask is even more important than in a place where there were 2 children per desk. So we have to see what do we have and how do we deal with it.
And,
Very good.
And it's the same argument we normally have.
Yeah.
You know, and I know Dr. Lois works in Kenyatta, and I see Kenyatta National Hospital being bashed all the time because there was a woman who was lying, you know, somewhere, and they were sharing a bed. You know, when for the health workers, they have to make that decision. What is most important? Is it this aesthetics, or is it actually saving the life of the woman and the child? So it's the same concept that we find ourselves here. What do? Do we call off school when we know there are so many ills? Child pregnancy, we know there are early child marriages. If you look, I guess there are a lot of kids who will not go back to school, and I've already seen the numbers you guys are presenting. So we also have to think about the larger ills and do benefit and risk analysis. As I said before, there is never a situation that is zero risk. Even without COVID, we still had risk of children getting measles in school. We had risk of children getting diarrhea in school. We had children going and getting other diseases in school. There's never a zero risk situation. The thing we are discussing is how do we risk mitigate within the existing environment.
And maybe that's why it's also very important to keep community transmission low, so that the number of children going to school with infection is minimized.
Starts at the community level.
Yes.
If it's low there, it'll be low in school.
It will be low in school.
Bingo. Wanjiro Bogua says, what I saw today while delivering my son back to school, a public national school, was impressive. Only he was allowed past the main gate. We were told everything will be done remotely, including fees, payments, etc.
Exactly. It's all these measures together.
They all make sense. All
of them.
We have to adapt to this.
Those decisions are made by individuals. A teacher in a school decides no one comes in. That's a good decision. Another teacher somewhere decides there's going to be water and hand washing, water and soap outside every class. That decision, it's all these additive. Remember, these are population level interventions. They're not individual level interventions, they're population level. So the more people in many areas who do majority of these things, the better we are.
Absolutely.
Yes.
Amos the third, assuming there's a first and a second.
Okay.
Amos the third says, I have some genuine concerns regarding the 3 classrooms, Dr. Lois. Okay. Says for boarding schools,
I think in that situation, we think about it as we're reducing the number of places where they have opportunity to be infected. So as opposed to having it in the dorm, in the class, reduce the opportunities for infection.
Yes. And time. And remember what we said. We said crowding, close spaces, contact, time.
Duration.
So if you have those 3 C's for only 10 minutes, then the risk is very low. But you have those 3 C's for 10 hours, then the risk is higher. So even when you keep them out, but even if they go, then you have reduced the amount of time that these 3 C's act together.
Guys are making a lot of sense today, man. I'm telling you, a lot of sense. Renee says, day one, Mom, how was school? Adriel, great. Mom, where is your mask? Adriel, I gave my friend in class. Mom, why? Adriel, he's got cut. Hapa in a cut to answer class are what to give and what not to give.
Very kind child. They've been taught well how to share.
You're saying sharing is scary. Okay, but if your child does come home with a friend's mask, you just let them know, right? Just say, look, this is...
Yes, you let them know that, you know, there's a reason why we don't share the mask. Explain to them in the simplest terms that if I've worn my mask, there are droplets that are on my mask, so it could have the virus, which means if someone else wears it, they could get the virus. And if I wear someone else's mask, I could get the virus. Then wash it for them and give it to them to return to the child in school. But I think it's just about explaining to them slowly.
Right.
It's going to be... We're going to learn a lot over the next few months. Nobody has all the answers. We really have to get innovative and learn and keep repeating the same thing over and over until the children get it.
Yeah, we have to be patient with these little people, Dr. Ari, don't we?
We have to be very patient with ourselves as well.
Yes.
Exactly. And we have to keep reminding them. So no, don't get into a panic because they came with another child's mask. Actually, don't get into, because when you get into a panic, the child gets into a panic, you know.
Yes.
So just as Dr. Lewis has explained, if it's a reusable mask, take it, put it in a place where there's a disinfectant, wash it with water and soap, hang it up, and the next day, pack it and tell it, you know, take it back to the child.
Very
so
good.
we have to work with the situation.
Yes. Wow. How many masks are they supposed to take to school with them? Is it one a day or two a day? Or?
So, I mean, what is reasonable is probably for them to have one a day. A cloth, whatever mask you can get, you know, a cloth mask. Some schools you'll see them with a surgical mask or whatever is comfortable for the child, because children may also struggle to breathe. So you want something that's comfortable for them. If it's a cloth mask, wash it so that they're not using the same one all week. That's just what is important, as long as they have a mask that's
Dr. G, boarding schools?
Boarding, it's the same challenge because, you know, what you're trying to do is, if you have space, then reduce the number of people together. Now, if you don't have space, then you just have to live with what you have. The thing that you need to do, there are many strategies you can follow, especially if you say, we don't have much space, but we have cubicles or we have dormitories, then avoid contact between dormitories, okay? So let's say you have, in my school, I think we had 7 dormitories in Nyeri High School. So you say, now that we are crowded in the dormitories, if you have a dormitory called Simba, another one called Chui, make sure those people don't necessarily meet. And maybe you may even have to reorder the dormitories to make sure that particular classes occupy particular dormitories so that you don't mix from Form 1 to Form 4 in one dormitory as we used to. You say these dormitories are for Form 1 or this class, that class, and then you make sure. In fact, in some schools, advise them, you can even mark actually, you can even put crowd control and say, you know, this cluster, this is how you go to your class, so that you avoid mixing. The less you mix the clusters, the better.
Yeah, and it's also important for when you have to do contact tracing, because infections will occur. We're not saying that they will not happen.
Correct.
And when they do, and you want to contain and control the amount of spread, it's important where you can contact trace and say, this child came from this class, but they didn't mix with from 2A and 3B and 4C, you know, they only are mingled with the people in this class. So if I need to test or contact trace, it's this class. So reducing that mingling is useful for contact tracing.
And the same thing for Simba and Chui houses, right? If it happens, a kid in Chui house
then
or
you
Simba
can
house,
track.
you'll know.
You can
Exactly. Good point. Saying Kiprotuka says, why is that Kenya doesn't have scientific research and data showing the trend of COVID-19 in the country? What are the opinions of the 2 doctors on COVID-19 vaccine yet to be rolled out? Okay, we talked about the vaccine. So saying we don't have the scientific research. But we've got KEMRI. KEMRI is doing a pretty decent job.
And if you're thinking about trends, trends is sort of the whole point of all the figures we're given, because that sort of tells you what's happening day to day.
What about
in
what
terms
we get
of
the last 24 hours? How about
that tells you what happened last 24 hours.
Oh, okay.
But if you're thinking about projections, there are 2 ways. One, we do modeling to say, if these factors remain constant, this is what we are likely to see. It really just gives a projection. may not always be accurate because different factors come into play. But you also have, as you mentioned, KEMRI, and some of the data they do around what they call serology, or looking for antibodies, to say, so many people have been exposed to disease. So there is work that's going on around sort of predicting trends.
Yeah, they shouldn't, we shouldn't discount ourselves or beat ourselves too hard, right, Dr. G?
We have a lot of data. Actually, when I saw that question, I think it's just that we haven't reached everybody. We have a lot of data on trends. Number one, the Emergency Operations Center of the Ministry of Health has been doing a report every single day from the day we had our first case, showing the trends by county, even trending backwards. Where are we? What curve? What's our positivity rate? Looking at the mortality data by age, by sex, by gender. All that data is released every single day, and it's available even to the media. So the data is available. Now the modeling of the future is also what is developed by University of Nairobi, KEMRI, and others. So the data we have is actually very impressive. I look at across the African continent, and I think Kenya is other than South Africa, which has really been ahead in terms of data. Kenya has done extremely well.
Wow.
But having said that, and this is for government, there's been very little funding released by government for COVID-specific research.
Yes.
And I think that's something that if we are to get ahead of the game, we have to be able to do a lot of research. That's how the UK has discovered that they have a variant. That's how South Africa is keeping track of their variant. So there has to be a lot more funding given for research to allow us to be ahead of the game.
Absolutely, ahead of the virus. Catherine Riungu says, I yell all the time in my house when I see masks placed all over the place. But looks like we don't know how to handle masks when we remove them, even in hotels. You will see it on the table. And I noticed you guys, you put yours on your arms immediately. I guess that's a habit, right? That's a habit. We have, go on, doctor.
We'll have to deal with the mask menace at some point.
Menace.
If you think about the number of this kind of masks that are all over the streets, I think we just need to think about how we will dispose of masks, and it's probably something that we haven't done a lot of education on. So I think that's a very good point, that we need to do more around education on disposal of masks. And if you put your mask on the table where everybody's touching, then it beats the whole purpose of wearing the mask. So we really have to think about responsibly handling our masks, that you keep them clean, you keep them on your person, you don't spread them all over the place, because then it beats the purpose of having it. Yes.
And that, it's the hardest thing to do, huh? But look at you, how you guys are doing it automatically.
Yeah, we do, because you see, the thing to understand is what she's saying, that what I always say, I'm a teacher, by the way. I always say, first understand what you want to achieve so that you can understand your actions. So what you want to achieve is to keep your mask clean and out of contact with other people. And therefore, when you think about that, then when you're sitting at a table, you're like, this table, somebody could have been sitting here. So sometimes you can just pick a serviette or a tissue, place it down on the table and place your mask. Sometimes you can just fold it and put it as we have done now. But as long as you understand, we don't have to tell you what to do with the mask, as long as you understand what you want to achieve. And what you want to achieve is to avoid contact of the mask with places that other people have touched or with other people, because then it beats the purpose of having it, wearing it, when it's been in contact with so many people.
Basically, you're just saying, it's up to you if you want to get the disease or not. That's what you're saying, right?
True.
Yes.
Yeah.
Wow, okay, let's get some closing thoughts. It's been a fantastic evening, and I hope we can have you guys more often to just, debunk this whole thing. I like that word, debunk. Very
Debunk.
nice. Yeah.
And you did not say debunk. You said debunk. I wouldn't let that go.
Dr. Lois, you go first.
I think we've talked about so many things, but the topical issue right now is about schools reopening. And one, it's important that our children go back to school. They've been home for a long time. It's important that they go back to school. So the issue is around how to make it safe for them to go back to school. It starts in the community. It starts at home. Let's be safe so that we keep our children safe. Let's do the right thing so that our children learn to do the right thing from us. Let's teach our children about masks, about hand hygiene, about distancing at home, so that when they go to school, they already have seen it in us and learned by aping what we do, but we've also taught them about it. Let's not only leave them to school.
Absolutely, good one. Dr. G.
I would echo the same words and say that the success of controlling COVID-19 in schools is dependent on the success of controlling it in the community. So let us not point fingers at schools and say, oh, you know, our children are coming. I've had people tell me they're going to bring the COVID to me. And yet those same people wake up every morning, go to the market, go to the office, and even go to restaurants. So let's remember that the success of the safety of our children and their teachers and the school community is dependent on our own behavior. It's not dependent on what the school does. That's important, but first and foremost, dependent on what we do and what our behavior is ourselves.
And just in case someone is joining us late, please quickly explain the Swiss cheese.
You really like Swiss
I love
cheese.
it. I love this thing. just break it down real quick.
So, you love cheese. So number one, we have multiple intervention points. None of them works on its own. All of them have holes. Masks, some people will afford them, some people will not, some people will have them all the time, some people will not. So we'll never achieve 100% mask compliance. The second level of defense is we are taught to wash our hands. Some people may wash, some people will have water, no soap. Some people will not have either. Some people will forget to wash, some people will even decide not to. So again, the hand washing works, but it has holes. Then we have social distancing. Then we hear, oh, you know, people in the informal areas cannot social distance. You can't social distance in school. You can. So again, social distancing has holes. Just like Swiss cheese, each piece has a hole. The most important thing is layer the pieces together so that each hole gets covered by another piece that doesn't have a hole. When you layer them together, then you achieve the result you want.
Just like that.
Very well explained.
Dr. Koinange Tai, you guys are fantastic.
Thank you.
Thank you so much, Dr. Lois Ombajo.
Sure.
MBS.
Thank you.
MBS.
What are you?
I'll tell you in a minute. In the meantime,
You're highly decorated. So get off us.
by the way, just to let you know, FYI, JKL is powered by Johnny Walker. Oh yeah, Johnny Walker exhibiting its eminence in electrifying quality and celebrating 200 years of blended Scotch excellence. How about that?
Sounds good.
Good stuff.
Charged by Johnny Walker, celebrating 200 years.
Awarded with gold.
Oh, guys, no. It's not until tomorrow, man.
Happy birthday to you.
Thank you, guys. In the meantime, we're going to go live to CNN, folks. This is where the story is. The U.S. Capitol, Washington, D.C. Thank you so much, guys. This is it's a day early, but hey. Dr.
We were here to celebrate with you.
Hold on.
You can remove this.
Yes, you can sit down. Nani?